Good evening. I am Alex Lowy. I'm a PhD student at Carnegie Mellon, and I'm here on behalf of the rest of my team, Joe Brew, Subbu Matindar, Andrew Reese, and our mentor, Eric Rosier. And our partner for the summer is the Chicago Department of Public Health. And the task which has been placed before us is to prevent infant lead exposure. Now, in a nutshell, the reason we want to prevent infant lead exposure is that if you have an infant who is exposed to lead, they will have significantly greater learning disabilities, as well as significantly worse learning. No, there's the perfect place to throw me off in every possible way. Worse learning disabilities, as well as significantly less emotional control for the rest of their existence, and this hits in about the age of 2. So we want to prevent infant lead exposure. This is the state of the art when it comes to seeing what lead is like in the city of Chicago. A child will be tested by their doctor. They will get a blood lead test, and this will happen either because their doctor thinks they are at risk or because they are following normal pediatric guidelines, which say that at the age of 2, an infant should be tested regardless. Now, they will have a level at or above 5 micrograms per deciliter, which is the CDC level for this is dangerous. In response to that, Chicago Department of Public Health will go and inspect their home to see if there are obvious hazards there. And if there are, naturally, they are now legally obligated to clean those hazards up. CDPH will come back and see if they've done so. If they haven't, this will keep happening. The problem with this is that you're already too late. If you have a child and they have a blood lead level, you know they will have blood in their system for the rest of their lives. It can leave the bloodstream within a month, but it will not leave the bones for at least 25 years, and if you have a substantial amount, you may literally have it until you die. And not only will it be in your bones, but it will be constantly leaching into your system as your body needs calcium and sucks it out, and instead of calcium, it gets lead. So this is a problem that is not to be treated. This is a problem to be avoided. The thing is, at the moment, we only have data on when the problem has occurred. And this is where we come in. Using the data that they gave us, and hopefully statistics, the problem is, this is a chunk of Chicago, and this is a house that had a child with lead in it, which is good for Chicago. It makes the problem that we were doing particularly difficult. And even more difficult when you realize that the risk factors for a leaded house are extraordinarily common. The most common epidemiological vector of lead in infants is flaking old paint. Children around the age of 2, they develop natural hand-to-mouth behavior. They'll crawl around, they'll stick their hands in their mouth, and that's where they get lead. The issue is that means any house that is in less than perfect condition, meaning the paint might be flaking, or has lead paint, which was outlawed in the United States in 1977, but still obviously didn't take it off the walls, is potentially putting a child at risk. And that means most of the houses in Chicago, in one way or another, are not in perfect shape or are fairly old. So we can build pretty good models of which these houses are, how much of a risk those factors impose, but we can't tell CDPH to go and inspect all of these houses because that would be a large proportion of the city. We begin to really get useful when we take the intersection of the houses and the children themselves, because if there's no child in a house, then there can be no risk to the child. And so when we start building models of bad house and young child at the same time. Now, as a minor aside, the big takeaway from this is that forget Ruby, forget Rails, forget Flask, and forget Julia. What you really want to focus on is data sharing agreements. Because if you have birth certificate data, we would do practically any unspeakable thing to get it by this point. That's what would close out this problem for us. But it turns out that there's a great deal we can do even without knowing where all the infants are. Naturally, if we knew where infants were, we could say, hey, here's a kid, they're going to be in danger. But there's a lot we can say about that even now. Now this is a map of, so these are trajectories taken from spectral clustering of age-specific blood lead tests in the city. Now, a bit of a mouthful, so let me just say, we threw everybody together, we said, hey, what's the average age, what's the average lead level at 1, at 2, at 3, and then each tract in the city had some average, threw all the averages together, and pulled out these 3 kind of canonical trajectories. On the map, matches by color, so people over here tend to have lead that looks like this over the course of their life. People in red tend to have lead that looks like that over the course of their life. And the important thing to take away from this slide is how distinct these are even at an early age. And what this suggests is that you can in fact tell how bad a child is going to get before they actually get there, even with a fairly small amount of existing data. So this is the kind of thing exactly that we're looking for. We want to avoid this, but we can only avoid this if we know that that leads to it. And that's what was not known before. This is only at the tract level, so obviously very granular. Not much we would want to act on directly with this, but we can make confident recommendations that testing needs to be done earlier. Like 2 is just too late. You can see here, 2 is in fact about the peak of when lead actually hits. And the thing about making this recommendation is that it doesn't even cost any more money, because there's a mandate that when you matriculate in Chicago public schools, you need a blood test along with your vaccinations, and along with your school physical, you need a blood test. But if you just took that test, which happens at 6, and is not that useful because lead isn't communicable, you could just push it back to the age of 1, and if you pay exactly the same amount of money and exactly the same amount of resources, there's perhaps a lot more that we could do in terms of upfront prevention. So that's me in my email if you have questions after the fact, but for now, I'll take questions. Thank you very much.
I was wondering, in that last graph, what were the numbers along the side? Is that the 2, 4, 6, 8?
Sorry, so these are micrograms per deciliter of blood lead. And 5 is thought to be, so we know these are inflated because we know we're missing a bunch of low tests, but 5 is what the city of Chicago says is dangerous. 7 is what I believe the state considers dangerous, and 10 is a national CDC strict threshold for crisis.
So that's like the average at the tract level?
That's correct.
Wow, that's really high for being an average, actually.
It's a biased average because
yeah.
Even with that, I mean, because I know a lot of people that don't have lead that get their kids tested, so I know there has to be some zeros in there. So
perhaps only ones, but still, yeah. That's
yeah. All right, thanks.
Sure. Thank you. Yes.
So, from 2000 to now, the level of lead in our kids in Chicago has just dropped off quite
precipitously. Yes.
So why can't we just keep on doing what has worked for the past 2 years?
Because we can, but why not do it faster?
I mean, so like, why did it fall so precipitously, and what operationally is it just accelerating that same process?
Sure. So the process is part of it. The nice thing about house remediation, which is what happens when CDPH goes to your house and said you need to fix this, the fixes that you employ are often permanent. So if a house was fixed in 1970, it's actually going to have been safe since 1970, because the kind of things that are done are, it's not like the paint in this wall, even if it were leaded, would be harmful to you. The place where it's bad are around the edges of windows, for example, because you open and close the window a lot, that's where it flakes off and gets into the air. So windows are replaced, and then the whole house is clean. So things like that have been happening for the past, well, much longer even than the 20s, much longer even than 2000. Beyond that, we're not entirely sure what have been all of the drivers for the drop.
Right. To follow up on that,
yeah.
You said that there wasn't a lot of testing in the early, before 2, so we have a lot more uncertainty. I mean, so your story that you just told was this, that there are really odd trajectories, and if we can tell at where people are at 1, then we'll be able to go forward. But isn't most of your uncertainty actually at 0 and 1?
It actually depends on, there is a funny problem with, well, short answer, yes. Longer answer, the uncertainty actually depends on where in the curve you are and on which curve you are, because different people in different tracts will get tested in different rates. So there are certainly robustness issues that we want to run this through. But we also have on the order of 3 million tests. So even if there's a lot of uncertainty, we also have a lot of data.
Okay, so you are, like, so you do have, you personally have a fair amount of confidence in the trajectory throughout the entire range.
We have enough to estimate it, yeah.
And these are basically mixtures? Is that, like, these are the kind of, like, is that one way of thinking about this? Is that these are, you could think of, that these are the kind of canonical mixtures from which a particular kid's trajectory is going to be cool?
That's how I consider them.
Okay.
Yes.
Did you say that you can't get birth certificate data and that's a problem?
We can, but very slowly and laboriously.
Why can't you get it?
So maybe a lesson for everybody, hopefully. Data sharing agreements. Let's see, our particular cases, what can be learned from this? Everybody had, well, I think 3 distinct IRB boards are potentially involved in our case when we're trying to coordinate between the city, the Chicago Department of Public Health, the Illinois Department of Public Health, and also the University of Chicago.
Could you explain what an IRB was?
Sure, of course. The internal review board is the body which makes sure that we're not going to do anything particularly evil with the data that we get, and that we're going to protect it, or we're not going to exploit the people who are in the data when we get that. But in the case where there is multi-organization collaboration, often every one of those organizations wants to pass it through their own filter. That's been one important reason.
I think that the short answer is it's a good lesson. And if you live in Chicago, the city of Chicago has no authority over people. It has authority over objects in Chicago. So plow trucks, cars, anything. Objects in Chicago, city of Chicago. People are the county and state. So county means people. So any data you need about people, you need to go above the city. So this project with CDPH, which is a city department, the birth certificate data is owned by IDPH, it's the Illinois Department of Public Health. And even CDPH has to get that data from IDPH. And so it's just government bureaucracy. It's going to take us a while. And eventually we'll get it and we'll use it and it will be a better city. But it takes months and months and months of dealing with this. So I mean, every project we're doing, we're sort of getting this confidential data that we can't, it's not open data. Most of it is not open because all these problems are dealing with data that is very sensitive. So we have to deal with all these things about getting agreements in place, making sure we don't release the data, we release the findings, we release the codes, everything we're doing is open source, but the actual data remains inside an organization. And so then we need to kind of go through these steps to get access to that data.
Is the remediation data available? Like when they reclaim or adjust the homes and like remove the lead?
Yes, it is.
Does that map with the green areas? Or?
Whether or not it maps with the green areas, that is not one thing I've looked at in particular. One thing we have found about the remediation data is that it doesn't work well. If you look at all of the remediation cases together at once, it's hard to tell how much remediation is in fact doing. It appears to be a tool that is applied without a complete understanding of where the lead came from in the first place. Something was the matter, we should definitely remediate. Maybe there was lead in the windows, but it might not have been the reason that there was lead in the child. So this doesn't really answer the question, but so we have remediation data, but it's even not necessarily super useful.
That was the question. That was the answer.
I mean, so then what is
Yeah, so
policy?
what are the policies doing if the remediation isn't directly affecting?
We're trying to figure this out in closer detail. We have every reason to believe from more carefully controlled epidemiological studies, environmental scientists looking at people who do this for a living, actually seeing what are lead vectors, that removing windows is a valuable intervention. It appears simply perhaps that the amount of false and targeted for this intervention is larger than we expect. Or it may simply be that we have very poor handles on sources of non-house-based lead, given the variables we have to work with.
you know, the people who live in the red parts of those maps have a higher rate of residential mobility than people who live in the green parts of those maps.
Yes.
You know, so, I mean, it's just like the people that, by the time that they are at their measure now, some of those folks have lived in a number of houses.
This is also known to be an issue, yes. So even if they're tested at one address, they may have gotten their exposure 3 addresses ago. That could well be part of the reason. Okay. Well, thank you very much.